morning, and thank you for keeping it Citizen Television. We appreciate your time and company this Wednesday as we begin our discussion on health and lifestyle. Today, we want to talk about uterine fibroids, something that unfortunately is very serious but has been taken and normalized as part of womanhood. That's unfortunate, according to a conversation I was having with the doctor I'm hosting this particular morning. And we're going to break it down, what exactly it looks like, how serious it is, how common it is, how it presents, and options out there in terms of the treatment and the management of fibroids, something that actually is also linked to the infertility issues that we are talking about out there. But I have the expert with me in studio who will be breaking all this down for us. I'm talking about Dr. Elias Walubengo Wakoli. He's an obstetrician gynecologist with us this morning in studio. Asante sana daktari for creating time.
Thank you very much.
All right.
Thank you for hosting me. As you said, I'm Dr. Elias Walubengo Wakoli, a gynecologist, obstetrician, a Kenyan by heart.
Huyu ni mzalendo.
Yeah, mzalendo, very patriotic.
Yeah.
I sing and pray patriotism.
Ah, nice,
Yes.
nice to have you this morning. And it's always exciting to talk about issues that are close to women, not because I'm a woman, but generally because some of these shows I have here are also platforms for me personally to learn. And this morning we want to talk about, when we are chatting, Daktari, this morning, I remember us even talking about this issue, and we were saying, unfortunately, it has been normalized as part of womanhood, and you were shocking me with the numbers in terms of incidences. And I want us to begin there. Just talk to us about the scope of uterine fibroids and how common it is, and do we really see it as that, big of a problem?
So let's start from the point of women. Women make up more than 50% of the population. And therefore, whenever they're affected, it means more than half the population is affected. And then we move to the next part where, when it comes to healthcare, the woman is the window into the health of the family. Men rarely go for antenatal clinic, but in antenatal clinic, we do so many tests that give us a picture of how the family looks like, how the husband looks like, how the children look like, how the diet looks like. You pick that from a woman. So women therefore become very important. Therefore, I normally say women daktari wajawazito na wasiokuja wazito, because whichever way they carry something that will give you a bigger picture of not just that woman who has come to the clinic, but you will get a picture of the family, and many times you will get a picture of the community just by handling one person. And you're able to actually handle a lot of things by handling that one person. So this morning, the issue of uterine fibroids is not a new thing. Most people have suffered it. They know someone who has or has had uterine fibroids, or have suffered the effects, or have gone through treatment for the same. And therefore, some people always ask, what is this? What is I? So the first thing we want to do is define what uterine fibroids
let's
are.
go there.
So the uterine fibroids are what we call tumors of the uterus that are benign. So the word benign means good in Latin, but in medicine it simply means not cancerous. That is what it means. Even though its origin in benign in most Romanic languages, Spanish, French, even Portuguese, benign is when they are telling you good. That's why the word bien comes in. So when we are looking at...
it's a tumor, but a non-cancerous
tumor. So that with a caveat, because some, in rare circumstances, can turn cancerous, but it is a non-cancerous.
Does it make it, is that a good thing, or does it make it less serious?
The fact that it is non-cancerous is an advantage in terms of its effect in bringing life to an end. So it is something that will be a scourge that will hurt someone for a time, but the chances that it will lead to fatalities is very minimal. So
it can be managed,
yes,
but it's not fatal.
So the question of what a fibroid is, it is a tumor of the uterus, and so it originates from the muscles of the uterus. It originates from just one cell. So the uterus is made up of soft, or we call them smooth muscles, and it originates from that one, and they grow and grow and grow and become big, and they grow and become many. Let me say most women by age 50 will have a fibroid. By age 50, most women will have a fibroid. It could be as tiny as half a centimeter, or it could be as huge as 15 centimeters. So 15.
When you say most women,
yes.
What percentage are we, or proportion are we working with?
So the numbers range depending on where the populations, because these are range that comes all the way from about 40% to about 80%. And talking of the black community, or the black race, we are genetically predisposed to fibroids. Our women are genetically predisposed, and therefore majority of these, when we talk of most, will be the black woman, because of some genetic makeup that we carry. And so black women tend to have fibroids more than any other population. Therefore, among black women, the population, some populations, it can go up to as high as 80%. Yet in the Caucasians and the Indians, Asians, you will realize that it's not as high, even though there are other, of course, and very important predisposing factors that will make one to develop them early or develop them late. When they develop late, of course, it's not a big issue. So the prevalence differs from one place to another.
Depending on which part of the world you're in.
Yes. And
in terms of age, do we have an age group that is particularly vulnerable?
Yes. The biggest risk factor is a very interesting one. Is something in medicine we call nulliparity. Not having ever had pregnancy, and by extension children, but majorly not having ever conceived is one of the biggest factors. And it is because the uterus has a job. The job of the uterus is actually to carry babies. So
if you don't give it that job,
if you don't give it the job, it finds a job for itself. And so it makes its own. However, it is not because it decides to make, but it's because when the uterus is in pregnancy, it is protected from certain hormones. And when the uterus is not pregnant, it is predisposed to certain hormones. Cyclically, for every woman, they have their month. Originally, we've always talked of 28 days, even though practically it's 21 to 35. But you see, the average becomes 28 days. That's why we commonly talk of those 28 days. So you are normally predisposed as a woman to estrogen, high levels of estrogen at some point, and it's a type of estrogen. There are actually 3 types. So after that, then there's progesterone. So progesterone tends to the formation of these cells, and then estrogen enables them to grow. However, when someone is pregnant, this type of estrogen is not there. They have a different type of estrogen that is protective. So a pregnancy of 9 months plus breastfeeding or something similar to that, you know, that will take almost 9 months again. Those are 18 months of protection. And if we're imagining that you'll have the next pregnancy 24 months after you delivered, then you realize in those 24 months, first of all, you are protected for 9 months of pregnancy, 9 months when you are lactating, or thereabout, plus or minus. And then you find yourself at a point where you're actually more protected than someone who has been exposed. So you realize it is common in women who have either fewer number of children or those who don't have children. And
isn't that giving women pressure to have children?
To a large extent, yes, and no.
It shouldn't.
Because there are many factors that are determined or determine the reason why one will have children, and not necessarily because you are worried about fibroids. And these factors, sometimes when they don't align, you have to agree that life happens.
It's true.
And then that's why we come in now.
Being a parent is a lifetime decision that you can't just make on a linear issue of trying to avoid getting uterine fibroids.
There are multiple factors.
I get you there. And how come many women you hear talk about uterine fibroids say the very first time they interacted with that term, or they were told they had, fibroids, was when they were during the first pregnancy, or when they had gone for ANC? I mean, why around that particular time? and what could be the issue in the society in terms of even the knowledge and the awareness about this issue that would lead many to be so uninformed about it?
It's a good thing that women normally make it to the hospital, either because someone has talked to them or because they are going for antenatal care. And in one of the things that are supposed to be done in the antenatal care is an ultrasound scan to look at the baby. But the baby is inside the uterus.
Yes.
So you eventually end up seeing things that you may call them a casual finding. Now, this casual finding may have an impact on the woman's reproductive capacity and process, or may not have a capacity at all to alter anything. But it's just a finding that someone will then inform you and tell you now, apart from seeing the baby who is doing well or however they are doing, we've also seen a fibroid of this size. And unfortunately, of course, that alarms so many people, because the next question is, oh, now I have a fibroid. What do I do?
That's why I'm telling you, most women find out on that very first ultrasound exam. That's when you're told you have and you're told it's this big, and you wonder, all this while you've never been told that.
So on my side as a doctor, whenever I come across that, I'm just a happy doctor. Because one, it does not have symptoms. It does not have symptoms. And because we don't always, we will discuss about management later, but we don't always manage fibroids unless there are symptoms. And one of the biggest challenges is if you don't conceive, you get fibroids, and if you get fibroids, you don't conceive. So if I find you've conceived and you have fibroids,
it's a good thing.
I'm happy. I mean, we are going somewhere. There's an obstacle on the way, but it seems like you have overcome the obstacle.
Bad,
or maybe it's not located on the road, it's just on the side of the road.
All right. So I know you have an illustration you'll run us through, but before we get there, what are these symptoms you're talking about? Other than just seeing it, you know, on the ultrasound exam, what else can be some sort of telltale signs that you need to go get checked?
So it's important that at least once a year, a woman has a visit to the gynecologist. That is a very important part to start from. And the reason behind that is because there are many things that could be going on away from fibroids that need to be looked at. And so if we ignore that, eventually we end up having casual findings or when symptoms show up. Now, fibroids, to us, we majorly look at what we call symptomatic fibroids, those that produce symptoms. And the first common symptom is infertility. In fact, most people, when they go to have a check for why they are not able to conceive, one of the findings commonly will be a uterine fibroid, even though that's not the major cause in this country in terms of infertility. It tends to be a major result. The fact that you're not conceiving now, you end up having fibroids, as opposed to it being the major cause
of infertility.
In Kenya. That's talking about our environment. But fibroids cause infertility because they block the tubes. That's one of the things they do. If they are close to the tubes, they block the tubes. When they are very close to the surface of the inner lining of
you can use the diagram to make it easy.
So holding these here.
To understand.
So this here is an example of the female reproductive system as you're holding it. So the whole from down coming up is the birth canal. Somewhere here coming up is the uterus. So this is the body of the uterus. From here coming, those are the cervix down here. The rest is the body. Then these are two tubes. Just below the tubes we have two ovaries. This one has been cut as a cross-section. So the inner part of the uterus is commonly known as the endometrium. And then there's the muscle that's around this. Then there's the covering, which could be like the skin. We call that the serosa. So the serosa, the myometrium, and the endometrium. The myometrium simply being the muscle now that actually originates those fibroids. So what happens is if fibroids grow close to the tubes, anywhere in this muscle close to the tubes, they block them. So
that's when you're told you have blocked tubes.
Yes. So that's one of the things the fibroids are able to do. So an egg may not be able to move from the ovary through the tube to come in, where the sperm is normally meets the egg in the tubes, comes into the uterus. So that's one of the things that happens that can lead to infertility. The second one is not normally just an issue of the blockage, but it's an issue of very early miscarriages that women do not perceive them. So that brings us to the next symptom, recurrent miscarriages. So very early miscarriages that may be perceived as heavy periods, because once there's fertilization, the fertilized egg is unable to implant itself inside, because wherever it wants to implant, there's something growing. So it's aborted or miscarried, that would be the most appropriate word.
So the fibroid is competing with the fertilized egg?
Yes.
Yeah?
So it is miscarried. Okay. As it is miscarried, you get a heavy period. You don't really realize you had actually been pregnant, because it happens just around the same time when you should be getting your periods. And it can come, a little bit late, maybe 2-3 days. So you think I had a heavy period and that's it, when actually you've been miscarrying. Now, the other is late miscarriages, the ones that happen after the pregnancy has grown. You're sure, you're happy you are pregnant, then suddenly you have lost it because the fibroid is growing somewhere, especially like this, it could be one fibroid. So that place is where the placenta is trying to attach, but is now unable. So that's the second most common symptom. Now, among the many symptoms that also follow is excessive bleeding. Excessive bleeding. During periods. During periods, women bleed not only excessively, but longer. So what happens is, it's common to change less than five pads or less in a day. But if you're changing more than 5 pads, then you want to ask what is happening. If periods are going for more than 5 days, then there's a question of what could be happening.
If you hear testimonials, other women would say they use both a pad and a tampon.
Yes.
For them just to manage the heavy flow that they go through. So there could be a problem.
So there could be a problem if they're having such a heavy flow that they may not be able to handle. So what actually happens is the fibroid being a mass, it increases the surface area that bleeds, because the area that bleeds is as tiny as we had already seen it here. But then when you have a fibroid growing, it increases the surface area that bleeds, and then it also hampers the uterus from contracting and cutting off the bleeding when it needs to cut off the bleeding. So that leads to heavy bleeding during periods. Then the next symptom that is now also important is the weight, the pain. Now, fibroids don't always have pain. There are many other causes of pain. Other things cause pain more than fibroids in terms of how often pain is caused by fibroids. However, fibroids can compress some organs, can compress some nerves, and that can lead to pain. And so when that happens, we explore, but we cannot ignore that there could be other factors that are causing pain and not the fibroids. Because for some people, you actually rush to remove the fibroid, then you realize they still have pain. Then you're like, okay. Or you do all the tests, you go in to remove the fibroid, then you realize they had something else which was causing the pain. So they cause pain, but it's not the most common thing. The most common thing that will happen next after infertility issues, issues of miscarriage, issues of bleeding, we will have compression of surrounding organs. Commonly, we simply say pressure symptoms. Unfortunately, when you say pressure, people think of blood pressure. So it's compression of surrounding organs. If the fibroid is located majorly on the cervix, on the front part, it tends to block the outlet of urine. So there are those patients who find it difficult to pass urine. Sometimes they need a position that they incline themselves. It's quite cumbersome because they can't find a position to pass urine. We had a case where someone has to lie down to pass urine because it compresses the outlet.
Or you need to go for the short course so many times.
There are those who go very many times because they are unable to hold. The capacity is not there because there's a fibroid that is blocking. And then for some, it can block stool. So those compression symptoms are some of the things that sometimes force us to look into what is happening. All right.
Dr. I want you to also run us through the types and the location. Yes. The simplest way you can.
Yes.
And the dangers of where, as doctors you say, depending on the location, that is how it shows you how dangerous it is. So just run us through different types and where they're located.
So the things we've discussed majorly are issues that will be important depending on the location, as you've said.
Yeah.
if they're located in one place, they may cause certain things more than when they are located in other places.
Place, yeah.
So the real full classification is about 8 types. Nobody will remember those ones
8
by the
types
time we finish.
of fibroids.
So we'll cut them into 3.
Yeah.
And again, I would go back to my little illustration. So the uterus has 3 parts, or rather this is the wall of the uterus. It has 3 parts, just like a house. You have the inner painting, which is a thin layer of paint. Then you have a whole thick wall of bricks. Then on the outside you have some rough cast or some painting. And those are 3 parts. So if you made a cut on that wall, you will comfortably see that the inner part has a paint, there is a wall, then there's an outer part. Or let's say there's a tile on the inside, there is a wall, then there's a tile on the outside. So we start from the inner part, so it's called endometrium. So these are just Latin words. By the way, these Latin words are very easy when you understand what they mean. Endo means inside.
Oh.
Metrium is uterus.
Oh, okay. So just make it sound...
So they're very easy. I know some people make these Latin words look more learned. It's just language.
Yeah.
We could also say it in our mother tongue.
So inner uterus.
So endometrium is the inner uterus. That is it. Then the myo is the muscle, sometimes called the mural. Mural is a Latin word for wall. I know we have paintings, we call it a mural because it's on the wall.
Okay.
So the next one is on the outside, is para, but commonly we just call it serosa, meaning a covering. So these 3 areas, the fibroids, as we agreed, all of them grow in the muscle. But they grow in the muscle closer inside the endometrium, so we call them those that are closer to the inner part, therefore. So then there are those that grow in the muscle, then there are those that grow on the outside.
Outside, yeah.
So if you have them growing on the inside, the inner part has a layer we call a mucosa, so we call them submucosal. So they are under that mucosa. These ones, when they grow on the inside, they lead to that heavy bleeding. They are the ones that cause the miscarriages. The closer they are the ones that cause majorly bleeding and miscarriages. Sometimes they can lead to some type of cancer of the muscle. So those are the ones that grow on the inside.
On the inner side?
Yes,
okay.
Those ones. Now, the next ones that grow in the muscle, depending on how close they are on the inner side, they'll mimic what happens on the inner side.
All right.
But if they are a little bit further, they may only lead to a compression. To distortion of the anatomy. So heavy bleeding can happen because if they are large, they increase the surface area. If they are not that large, they may be inconsequential. If they are close to the tubes, they may block the tubes. If they are not, they may be inconsequential. That's why sometimes we look at, you're doing fine. And you imagine, why is he ignoring the fibroids I have?
There are people who are concerned about, doctors ignoring the fact that you have fibroids. So they will tell there is no cause for alarm.
There's no cause for alarm because we put several factors together. I want to apologize for doctors. They're poor communicators. They think 100 things and say it in one word. So they have looked at many factors and simply tell you there's no cause for alarm.
Or we wait and see.
Yes, they have looked at your age, they have looked at your race, they have looked at the children you have. All those things I've looked into, then say there's no cause for alarm. That has already happened in their head. So I want to say I'm really sorry for the fact that that's what we do. But naturally, looking at those factors, it is in the muscles, it is not large to cause a lot of bleeding. We are not worried about it. Now, it is large, it is increasing the surface area on the inner side, it is bleeding, or it's large in the muscle, yes, but very close to the inner layer. That becomes an issue. Problem, Then, of course, there are those that grow on the inner side. They grow until they grow a stalk. Then they now get delivered, like a baby would come out, then hang now in the birth canal. Those ones definitely are very cumbersome because they bleed continuously and you could feel a mass in the birth canal, which is very cumbersome. You can't sit with people, you can't really have a quality of life.
How true is the fact that a fibroid can be as big as a baby? That there are women who actually look pregnant and it's not because they are, but it's because of the fibroid. Is it true?
Yes, it is true.
It is true, yeah?
It is true. A fibroid can be as big as a baby because it can grow until it compresses. You're talking of compressing. It compresses the diaphragm and makes someone unable to breathe well, to breathe even while lying down. They have to be in a semi-seated position, so it can actually grow.
All right.
So there's the last type, those ones that grow closer to the wall on the outside. They hang around, they don't have much problems, except when they twist. Then they cause a lot of pain.
All right, so how does, I know you've touched on this a bit, but how does it affect the menstrual cycle and fertility?
So we'll look at the menstrual cycle. The cycle itself is not affected. So on the side of the woman who is suffering this, the cycle is affected. On the side of me as the doctor,
it's not.
The cycle starts on the day it should start. It ends on the day it should end. Now, the cycle starts on day 1. Let's use our 28 days. Ends on day 28 when the new cycle starts. So the cycle is fine. However, the period through which the woman bleeds is longer. So you fail now to define the cycle as a woman yourself, because you're bleeding for 14 days and you're wondering, when will this bleeding stop? And then after it stops, just 2 weeks later, you start again. So you're like, my cycle looks funny. So it affects, therefore, the length of that period when you bleed, the menstrual period itself, as opposed to the whole cycle up to the end. So the menstrual period is affected because it is heavier, given the surface area, and it's longer, given the inability for the uterus to contract and achieve coagulation. That is what I would say.
All right.
So those two things, it becomes longer, it becomes heavier. But it is quite cyclic, that you can actually time it, that the period starts at the right time, but then it seems to continue.
All right. In terms of fertility, so does this then interfere with fertility?
Yes,
because even when you want to have a baby, there's usually the timings.
Yes, it does, because if you're bleeding all along, you're messy, one of the things is it will affect your relations. And that's one of the things. So you may be during a fertile window where you're still bleeding, and you are therefore untouchable for a good number of people. And as a result, that potential conception for that month will have been forfeited. The next thing that will happen is when you're having these fibroid, as I said, it blocks the tubes, so it makes it also, sometimes when they are close to the tubes, they block the tubes, makes it impossible for one to conceive naturally, because it looks like you already have a family planning method that is permanent now.
What about somebody who has already managed to conceive? Talk to us about the complications that can arise as a result of having a fibroid.
So once one has conceived, the baby needs to attach somewhere. So the baby is normally attached to the mother using something we call placenta. So there's a cord that runs from the baby to the placenta. The placenta belongs to the baby, but it attaches on the wall of the uterus. So where it attaches, it looks to get nutrients and to get oxygen and to eliminate toxins back to the mother for the mother to get them out. So if it's attaching, therefore it needs a place where there's good supply of blood from the mother, which doesn't cross, but as it passes across, if there isn't, the placenta tends to continue widening, looking for space to attach. And in a place where it doesn't attach well, it may detach. What that does, number one, is there's bleeding during pregnancy. So you find women who have a lot of bleeding during pregnancy. Today they bleed, tomorrow it stops, it bleeds, it stops. And if it doesn't attach well, then, or it's growing towards a direction, yet the direction it's going to is where another fibroid is, you find now there's a miscarriage, because the baby is growing fast and has needs, but these needs are not being met. So as a result, the baby also dies, or the placenta simply detaches, and now you lose the baby. So it leads to miscarriages for those people who have conceived, or difficult pregnancies where there's a lot of bleeding in and out.
Talk to us about the hormonal competition in terms of, sometimes you doctors have a way of explaining it, that the baby and the fibroids are competing in terms of growth and the hormonal balance in there. So just break down that complexity for people to understand.
So let's come to, I know we commonly use layman terms to make it easy and quick
to understand.
But the depth of it is that fibroids actually don't grow during pregnancy. They tend to increase in size when you're looking at them. But if they were 5 centimeters at the beginning of pregnancy, when you have a pregnancy, when you measure, you may find it's like 6, 7, but immediately the woman delivers, as the uterus comes down, you realize they come back to where they were.
Okay.
So actually they don't grow. But then the other good thing is, as I said, pregnancy, therefore, once someone is pregnant, they look like they have grown. They cause majorly a lot of pressure and pain. And the worst is now the competition for blood supply. So a lot of blood supply majorly is facing the direction of the baby. So when they are not supplied with enough blood, that's what happens. They die off. We call that necrosis.
So pregnancy can be actually is a good thing.
Yet at the same time, it's very difficult because the big ones, as they die off, they cause a lot of pain.
Okay.
It is extreme pain that we have to admit people and sometimes look for how to simply manage that pain. And sometimes there's no drug that's working for that patient. Remember, the patient is pregnant. The drugs that we are using for this patient are limited because there's a baby who cannot get everything you would give. You see, if it's just somebody out there, you would give anything, a lot of things, and they'll be fine.
Options,
but she's pregnant, you have a limit of the drugs you can give, even the dosages. Yet at the same time, she's in a lot of pain that you have to imagine between her baby and her pain.
What do you choose?
What do I prioritize? So that's the biggest part as opposed to the hormones, because the placenta, once we reach about 12, 13 weeks, the placenta tends to sufficiently produce hormones that can sustain the baby. And these hormones, for example, the estrogen produced in pregnancy is not that strong for the fibroid to continue growing, and it's not even the type because
that makes it grow.
Okay. So as a result, it's normally a protective factor to a large extent, that you will have the fibroid that you had with the size that it had until the pregnancy is over, only that it will look larger because everything in pregnancy tends to increase. After delivery, after you recover, you realize it comes back. So there's not much a competition between the fibroid and the baby for the hormones. But yes, in the natural state of a woman, the fibroid competes for hormones. In other words, it grows because of a certain type of estrogen, but once it is growing, it tends to even convert any other estrogen into that estrogen that enables it to grow.
Okay.
So it's like it makes its own food now by force.
It is struggling to survive also.
All
right, so Daktari, talk to us about the options out there for treatment, and when treatment is not an option, management of fibroids. So what informs a decision of one over the other? There is even surgery that is one of the options. So talk to us about what's out there.
So the first thing that is out there is doing nothing. I know nobody likes hearing that.
You do nothing.
So we don't always have to treat things.
Okay.
Yeah. There are things that, and people get annoyed sometimes when they're told by the doctor that this does not need treatment for now. So we call that conservative management, where you look at it, you assess where it is, you assess the age of the patient, you assess the number of children they have, and a few other things, including complexities, the benefit and risk ratio. Then you tell the patient, we are not going to do anything about it. We will monitor it. So that's the first thing.
That's what many patients don't want to hear. They want something done.
So something done now depends on the symptoms that we talked about, because commonly we treat symptomatic fibroids. So if we are looking at fibroids and their symptoms and the age someone has, sometimes we manage first tier things like just bleeding. This is daily management or as they happen. So if someone has bleeding, we would put them on some hormonal drugs and some drugs to handle the bleeding, which simply help the blood to coagulate. Because we agreed that one of the things, the uterus cannot contract well to make them coagulate. So we can give a drug to help coagulate, and we can give hormones to now help that cycle.
Okay.
We talked of the cycle and how you're looking at the cycle and feeling it's affected, and you want to know where is the cycle starting. So you put the patient on some drug, it enables them to run a cycle so that you know where is it starting, where is it ending. So these hormonal pills that we give, they do help. That's normally the first thing that we do for most patients, conservative management, then we come to pills. Now from there is what we call medical management, which is just drugs that we can actually inject. Some of them can be swallowed, but majorly we use injections. They block certain hormones, and for this matter, they block that type of estrogen. So when they block that type of estrogen, it ends up at a point where the fibroid is no longer feeding on estrogen, so it starts shrinking. So it takes time to shrink. So this is also what we do in the clinics. We easily put in fibroids, we put in some hormones, or we block some hormones, and we do that routinely on a monthly basis, so it can be once every 3 months, and we shrink them. Once they have shrunk, now you decide, do you need to operate? And if you're operating for that matter, it may be sometimes a whole removal of the uterus, or do we need to remove the fibroids? And if you're removing the fibroids, normally we may not shrink them, because sometimes they get lost in a mixture of things. So what we first of all do is these drugs, we inject them, they block the hormones, the fibroid shrinks, it alleviates symptoms, a number of the symptoms, not all of them, and life goes on. Now, the next thing that we do is we do surgery.
So now, that's like it cascades. So
yes,
that's like among the last options?
Not really. Options are chosen depending on the circumstances
situation
of someone. Because you find people who is aged 50 years old, she has 4 or 5 children, she's not looking for other children, and has other diseases that may not enable us to do surgery. Menopause is coming, so menopause is likely to shrink them. So we may just give management that is simple to handle the symptoms for now until she reaches that menopause, and we stop, we don't do anything. But you find somebody who is younger, they need a family, you will not go for the drugs that we are talking about, because those drugs may still affect the patient. We straight away need to remove these fibroids so that we can get, or we find somebody who is at the verge of ending their reproductive age, you know, somebody above 35 to 45, they still want a baby, and you need a way out. One is you want to remove so that they heal, so that they conceive.
So time is of essence.
So time is of essence. So we make these decisions depending on who we are facing, and not necessarily, and what we are facing, and not necessarily cast in stone that this is how we cascade. No, we may start from one position and the other. Find somebody who is bleeding excessively, has fibroids pressing their inability to breathe, and they are 50 years old, they are not able to breathe. You just will have to remove the uterus. Now, surgery therefore comes in, the first one being removal of the fibroids themselves, depending on the objective of what you want to achieve. So whatever you want to achieve determines what you will do for that patient. Another one doesn't have children, but has issues breathing, has issues even passing urine. So you have to remove the uterus for that one. Then there are those where we just want to shrink them, and we look for other methods to shrink, including sending some chemicals into the blood vessels. We call that embolization, where we block the blood vessels that go to that fibroid or that go to the uterus. So there's no blood, then they die off. And currently there are better ways of doing it. There is technology commonly called HIFU or HIFU. It is high intensity sonography, ultrasound, which is normally focused. So they call it high intensity focused ultrasound. That's where the HIFU comes from, where the fibroids, either through an MRI guiding or just the ultrasound alone, they're able to actually burn them and coagulate them. And evaluation is done at 3 months, 6 months, 1 year, and they go shrinking slowly by slowly as they're followed up. It's something that is...
So that's more targeted?
Yes, it's more targeted area. And there is no surgery. It is just ultrasound. And then follow up until the shrinking has reached either the size we need or they have completely disappeared.
All right. I'm curious to know about the traffic in terms of those who come to visit and find out, or even get their diagnosis, because one of the biggest challenges that we have today about uterine fibroids is the lack of information, the delayed diagnosis, misdiagnosis. You'd go to a facility for several months seeing the same doctor, and you'll get, by the time they discover that you have fibroids, it has taken so long. So what could be the issue and what's happening?
The issue is a system issue. Because we are looking at a large population, In Nairobi, I think a majority of the people have a capacity to access somebody who can do an ultrasound scan quick. It is not the same thing all over the country. So you will realize that I traverse, for example, all the way from Kitale to Nairobi and its environs. Environs include Machakos, Kajiado, Kiambu and Murang'a. And I know that the people who live along this corridor of the road that comes from Lunga Lunga passing to Malava, 100 kilometers away, they always tend to access services. More than 100 kilometers away from that road, these services sometimes are a dream. And so when you go to the nearest person for whatever you have, they'll give you what they have. And what they have is normally does not include the tests. This simple ultrasound scan. So by the time they come to realize you have a fibroid, it is big, it is touchable. We call that palpable. You can now touch it and you're like, oh yeah, I think you have a growth. Now you know that's where it starts.
You realize this person started having issues way back, but by the time it's being diagnosed, it has taken time. So
they have had a long time. Then when someone touches and says, I think you have a growth, then I think you need to travel. So you're traveling some more than 100 and something kilometers to have something called an ultrasound scan done. Then where you will, after it is done, you will be told you have a fibroid. Then you'll travel back to that person who will now tell you you have uterine fibroids and now they need to be removed. That will be actually the answer naturally. And now you need to be again referred, again 150 kilometers again to somebody else who will see you in the clinic and then book you next month. Because this month is full, he has a list. Next month is full even. So as they are booking you, we need to do preliminary tests, which we don't have reagents. Can we also send you, or we'll get a sample, or we send you 200 kilometers again to go have that done. Then when you have the results, we are sure, okay, good. Now we can attend to you. Now, before we attend to you, we need blood.
Okay.
Oh no, but schools have closed.
So the back and forth continues.
So you realize.
The back and forth.
So the burden for me is not along this corridor that I know we all get to go to where we want to go. The burden is normally away. Now, along this corridor, it's normally the lack of information. People who just may not know that it could be a fibroid, but rarely do people miss it once a scan has been done. You can confirm. You can see it. What
about the normalization of fibroids? You'd hear, like in a family, auntie so-and-so, so it's okay. I mean, if so-and-so dealt with it, it's okay. It's no cause for alarm. Is that also a problem?
So fibroids will be normalized because in the first degree family line, the propensity of having them is about 2.5 times. So imagine if you are a woman and your mother had fibroids, you are likely to have them. The chances that you will have them, it's not that you will have them. It is, we call it probability that you will have these fibroids is 2.5 times.
2.5 times.
If your mother had them. So you're looking at something that has recurred in the family. Now imagine you have 4 sisters. So, and you're the youngest, and your mother had fibroids, your 4 sisters have them. What do you imagine?
You could. The chances are very high.
Now, the first your mother was told, we don't need to remove them. You're doing fine.
So that's why they advised you, Aina Shida,
and
that
then,
could be a
so
problem.
depending on the factors, your elder sister got married, Ali had children, then they found a fibroid, and they told her, we are not worried, we don't care. The next one, then you are the only one having symptoms. So we manage symptomatic fibroids, so we don't normalize them. We manage symptomatic fibroids. So those who have been told that theirs are not symptomatic tend to spread this information which is the wrong information. That, we don't need to do anything. So it's like when you've been given Panadol in the hospital because you have pain, and you reach home and your brother also has a pain, and you think Panadol will work for him. The truth is his pain may not be responding, may not be anything that can respond to paracetamol. That's what happens.
Thank you for saying
that's how fibroids work. Because you are told yours have no issue, so you go and tell the other one, just the way I was told. It doesn't apply.
I had them and I had children.
Yes.
So you advise another woman,
and that's a very common thing.
Yeah.
And I like to advise Kenyans to stop.
Let's go to the hospital. Thank you for saying that. Any other misconceptions about fibroids that you're concerned about?
So I look at, people look at fibroids as the end of life. It's good to know that there is care. It is not the end. I think that is one. And then, of course, in a large part, people think it's related to witchcraft. You have a growth in the lower abdomen or in the abdomen because it is witchcraft. No, it is something growing that needs care, and it can be taken care of. Because sometimes even when you are removed, we show patients, and they're like, yeah, this is witchcraft. I'm like, no, it is not. It is something that has been growing. It is abnormal, yes, but it has got nothing to do with witchcraft. So
how big can it get, like in terms of the experience you've had, yeah? What are some of the concerning cases that you have had in terms of size, in terms of even the numbers? There was one testimonial I had when I was prepping for the show, and there was a woman who was saying that after the surgery, it was like a small bucket full of different fruits of different sizes, a berry here, an avocado here, like there were quite a number. And fortunately, after that surgery, she was undergoing an IVF treatment process, and that's when the fibroids were discovered. And then one of the options, according to the doctor, after assessing her, it was to remove them, which was done. And then fortunately, after that was done, she managed to conceive naturally, which was a good story to interact with. But I was shocked to find out that it can actually be that many, so fibroids.
They can be very many.
Yeah.
Because in one patient, sometimes you removed as many as 20 pieces.
From one person?
That is in numbers. Now, sometimes you just get one. That is very huge. I would want to use a very bad example. You see, I do not have a very small head.
So as huge as Dr. Alubengo's head.
Yes,
it's
and
funny
it is
when
just
you say
one.
It's a very serious issue.
It is just one, and you're looking at the patient and looking at the patient again, and trying to imagine you need to do something, and you do all the scans. What you're seeing is one, and when you open, you get it out, it is one. But it is one huge fibroid rather, and so they can be very large. Now, I've had a case of a patient who developed difficulties in breathing. They have to be carried to the hospital. Actually, they carried the hospital, brought her to my bench, and told her, until he sees you, we are not going back with you. And those were colleagues from work. So I arrive at work, I find somebody there in severe pain, because now they have reached that limit, difficulties in breathing. So I'm struggling to wonder, do I give oxygen first? Do I? And until he sees you, and then I was like, this is a dramatic one. Then I've had one that we call it ectopic. It's not on the uterus. It began its journey growing on the uterus, but got attached somewhere else. Then it began growing there. So there's a mass in the abdomen. Everybody looking at it says we have a mass in the abdomen. So of course you have to do the surgery, you get it out, take for testing, it's a big one. Then the result comes out, it's a fibroid, not at all attached on the uterus, but the origin was the uterus. It broke off after it attached somewhere else.
So those are the unique
cases you will find. And of course, they are all sad. Nothing a doctor tells you is interesting. There's normally a sad case. So
and doctors have a way of giving you this plastic face of, it's fine, it's okay, when every other thing is falling apart. But they wouldn't put you in that state of getting worried.
Hope.
Yeah. I have a very few minutes left, Daktari, and a quick question. Can they recur? And what usually causes that?
Yes, fibroids can recur because the primary causes are the same.
Okay.
The primary causes, as I said, is our propensity, especially the African woman, propensity to estrogen is such that it has not changed. So if fibroids have been removed, you can grow others. And they do grow. So they do recur. It's not something that you will treat permanently. It's something that you need to work around and decide case by case with your doctor.
So for a woman who is saying, never again, like I've been through this path, I don't want to be here again, do you have something in terms of management or prevention or, you know?
Yes and no. Because even those that we are doing hormonal therapy, we don't do it for long. It has its effects.
Limit, yeah.
It has its limits. As we block hormones, as we give the drugs we give, there are limits. So we do those things normally to prevent, normally to sort of prolong the fact that the fibroids are going to come. And so the biggest assessment is, what is the biggest age bracket that suffers this? Somewhere around 35 to 45, they tend to have the bigger ones, the ones with the biggest challenges, the ones that portray the symptoms that we talked about, somewhere between 35 and 45. So you realize most people, if I am dealing with that scenario, I'm just pushing it so that because I know menopause is coming.
So that you pass that season.
Yes. And the other part is, for those that are able to conceive, that normally sometimes becomes a recommendation, because it's one of the symptoms sometimes, and many times, infertility. And so we start exploring fertility, because one, it will be a protective factor, and two, we will have achieved the goal. Because for me to touch a fibroid, what is the goal?
All right. So lifestyle, kuna fears kwamba what we eat or the way we live our lives these days, these products we use are the ones that are causing fibroids.
Yes, that is true.
It is?
So when we talk about risk factors, I said one of the risk factors is just being an African woman is a risk factor. Having had it in the family, especially first degree family, your mother, your grandmother had, is a risk factor. So then we move on to the next risk factor, which is obesity. Obesity. Yes. Now, this will need a very serious medical explanation of what obesity does. Increase in weight is fat majorly that increases. From the lean weight that you have from your muscles, all of us have fat that is normal, natural. When it increases, it produces male hormones, if I may use that word. They are called androgens. So these androgens undergo a change process by a chemical that changes them to estrogen, and commonly to that very type of estrogen that makes fibroids grow. So you have your estrogen from your ovaries, but you also have estrogen that is coming from fat. So fat broke down, gave male hormones, that broke down, gave the female hormone.
The female hormones are making
the growth of the fibroid. So that is where lifestyle comes in.
Basically. So watch what you eat and how you live your life.
So how you eat, what you eat, exercise is important. It helps. So that's where lifestyle would come in as one of the factors.
I'm out of time, Daktari. Final words.
Yes.
Yeah, just your parting shot.
So my parting shot is fibroids are a reality. It is something that can be managed, and it should be managed. It is important to have a discussion with your doctor so that you know what symptoms do you have and what objective do we want to achieve with the management of the fibroid that you have, so that you do not have to think that all of them must be managed. But it's just that to handle whatever they are causing. Top on the list, as we talked of, fertility, issues of miscarriage, excessive bleeding, pressure symptoms. Those four are the most common things, apart from, of course, pain.
Thank you so much.
I think will be managed.
Thank you so much, Daktari, for talking about this very sensitive subject that has been normalized. But like you're telling us, it's case by case. What could be happening in one woman's body is not the same as what could be happening in another. So it's important to visit the nearest health facility to get your own case analyzed and checked. And depending on your goals, your age, what you want as a woman, that is what is going to help you achieve whatever it is that you want to achieve in terms of health outcomes. Today we are talking about uterine fibroids. Thank you so much for watching as well. My name is Safina Chengoma. Asante sana. Have a lovely day ahead.